So now we will invite Dr. Prashant for his talk on uh, implants. So Dr. Prashant, let me just introduce Dr. Prashant. He's a glaucoma consultant at Netralayam and BBI Foundation. He has done his long-term fellowship and worked as consultant in the Department of Glaucoma in Shankar Netralaya. He's a very well-known instructor and speaker at various national ophthalmic forums, and he has many publications in peer-reviewed journal. So let's have Prashant for his talk. Prashant, over to you.
Yeah. Thank you so much, Dr. Sagar, for your kind introduction. So I'll be talking about this. My slides are visible now?
Yeah, it is visible, Prashant. Go ahead.
Yeah. So I'll be talking about the role of drainage implants in the glaucoma surgeries. First of all, I would like to say that I have no financial interest in any of the implants or surgery or any techniques. Basically, implant is indicated in cases where conventional trabeculectomy is failed, and the use of one second. Basically, implants are indicated in cases where the trabeculectomy is failed, either failed or most likely to be failed. These are the cases of refractive glaucoma in which the chances of success of trabeculectomy is little less as compared to the conventional. So we can directly go for an implant patients. So basically, implants are of two types: valved and non-valved implant. What an implant does is it connects, it is in the form of tube, connects anterior chamber to a subconjugal space. So it drains the aqueous directly from the anterior chamber to a subconjugal space. So there are two types of implants. One is non-valved and valved implant. Non-valved doesn't have any intrinsic system of valve. So aqueous outflow is actually maintained by a development of fibrous capsule which forms over the period. So initially you have to ligate to minimize the overflow of the fluid. And the other type of implant is valve. They have an intrinsic system of valve, so that regulate the amount of aqueous going into the subconjunctival space. So Ahmed is a type of valve implant. This is a valved implant, which is a prototype. It's a large side barium implanted implant, which is a large silicone tube. This is a non-valved implant again. It has fenestration at the base plate, which allows the fibrous growth of the tissue. So with time, a fibrous capsule is formed over the implant, which helps in providing the resistance to outflow. This is a Molteno implant. It has a plate, acrylic plate, and a tube. There can be a two plates implant also, and V-shaped pressure ridge implant also. Now, the implant which is used by us mostly is the Ahmed implant, is the valve implant. FPA7 number implant is mostly used in adults. So it has a base plate and a tube, and the base plate has a valve which has a silicone elastomers which collapses when the pressure is low, and so thus it prevents the outflow of fluid. So indication of doing an implant is the case of failed trabeculectomy, as I said earlier, and the cases where trabeculectomy is most likely to be failed, like cases of iridocorneal endothelial syndrome, uveitic glaucoma, infantile glaucoma, Surge-Weaver syndrome, neovascular glaucoma, and glaucoma with PK, post-PK or corneal transplantation, and also certain cases of VR surgery, post-VR surgery, the patients develop glaucoma. In such cases, implants are very much useful. Now, what are the sites where implant? The one big advantage of these implants over the trap, that a trap can be done only in the superior area of the eye, whereas implant can be done also in the inferior. So inferior temporal implant can also be done. Also, we can do a superior implant. So this is a superior temporal implant. Here we have an inferior temporal implant. Implant can also be done in cases we have a extensive thinning of the sclera. So in this case, it's a uveitic case where you don't have a good conjunctiva and don't have a good sclera to support a trabeculectomy. In such case, implants can be used. Now, implants can be put beneath in the sulcus behind the iris, and can, like in cases of post-PK glaucoma, where if we put the implant anteriorly, there is a danger of touching the graft or the cornea. So we can put it in the sulcus, so it stays away from the cornea, so there is minimal chance of two corneal touch. Now, this is a surgical video explaining the implantation of the how the valves can be implanted. First of all, we mark the area around 3 mm from the limbus, and open a conjunctiva, doing a conjunctivomy, and then peritomy, and then we have to elevate the conjunctiva along with Tennant's capsule. This step is very much important. It's called priming of the valve. It ensures that the complete system is air-free. So here the priming is done. So we can see the gush of fluid here. So priming is done. Now this is a FP7 number of AMAT glaucoma valve. Now holding the implant gently away from the base plate and pushing it back. The next step is to anchor the valve over the sclera. So generally it is done around 9 meters away from the limbus. So it can be done by 9-0 nylon suture or 10-09 suture. So once the valve is anchored, then we create a paracentesis, and then we mark the size of the tube should be given inside the eye, and cut the tube in the bevel head up direction mostly, so that it doesn't get blocked. If you're putting in the anterior chamber, it doesn't get blocked by the iris. Now, with the 23 gauge needle, we form a track, and through this track, this implant is pushed into the anterior chamber. So now we have an implant inside the AC. So now we are fixing the implant over the sclera so that it doesn't get dislodged with the 10-0 nylon suture. Just it is not ligated here. Just the purpose is just to anchor the implant and support the tube to be in the position. Now this tube has to be covered by a graft. So normally the scleral graft are used, donor preserved scleral graft. We can also use a donor cornea, which cannot be used for PK. And after that, we can suture the conjunctiva, watertight suture with running 8-0 Vicryl suture we can use. So this is how the normally the implant surgery is done. So after once you have done with the surgery, you have a post-op period in which an implant has initially hypotensive phase for a period of 1 month, where you have a diffuse thick walled bleb. The pressure will be low. But after 1 month or so, the pressure will increase again because of formation of the fibrous capsule. So there will be little inflammation, and the bleb will appear little dome shaped. Once this phase passes off, then you enter into a stable phase where IOP is usually in lower T. There can be certain complications with your implant surgery also. Particularly if you're not using a valve implant, you can get hypotony. Even in cases of valve implant, there might be leak from the edges of the paracentesis or the track that we created. So you can get hypotensive phase initially. There can be tube obstructions like this with the iris. There can be tube exposure. And sometimes the tube retracts, then you have to put explant. And this is a photo showing that the exposure of explant also. So explant can also get exposed. So it is very important to cover that with the graft. There can be cornea endothelial touch, and also there can be ocular motility disturbance, particularly if you're doing it in the superior nasal quadrant. That is why superior nasal quadrant should be avoided, because there is a very little space over there. So you can get a motility disorder. So there are a few examples where implant was very helpful. This is a case of 45-year-old female patient, had a visually significant cataract with IC syndrome, and IOP was 32 millimeter of mercury. You can see the cataract was significant, and patient had IC syndrome. You can see the cells were less. So in that case, the phacoemulsification was done with viscoat cover to protect the endothelium, and the implant was done. And you can see the implant here in the sulcus. So it gives excellent result. We can also do a TRAB in cases of IC syndrome, but generally what happens when we do a TRAB in IC syndrome, we get a very engorged vessel, angular-looking vessels over the conjunctiva, which limits the chances of success in IC syndrome. So we can try doing a TRAB also in IC syndrome, but the success of putting an implant is much higher. Now this is a case of cornea, decomposite cornea, where the implant was done along with a DSEC procedure. Here again, we can see it was well placed in the sulcus, and it is away from the graft, and which gives excellent result. So it was done with DSEC and AGBS done together. Now, patients with corneal opacity and uncontrolled glaucoma, we can plan penetrating keratoplasty along with the implants, putting an implant together. So which gives excellent result. Here in this case, the pressure was well controlled after 3 months of therapeutic PK. Once you have an implant after penetrating keratoplasty, it may, after some time, the pressure may again arise, may be out of control, and with maximum medication, then you can consider putting 2 implants. So one implant is there in superior temporal quadrant. You can still put an implant in inferior temporal quadrant, which can control the pressure. So 2 implants can also be applied. Now, cases of neovascular glaucoma, as we know, the neovascular glaucoma is very aggressive disease, and the chances of success of trabeculotomy is very less. So in such cases, there are good candidates of putting an implant rather than doing a trabeculectomy. So this is the case of neovascular glaucoma, where putting an implant, so we can see the hyphema here, putting an implant was able to control the pressure. That is why it has gained popularity in the surgical management of neovascular glaucoma. In uveitic glaucoma, because marked inflammation in post-op period, the chances of bleb success is less as compared to other cases. So in such cases also we can put a implant. As I showed in the earlier slide, in sometimes in uveitic glaucoma, the superior sclera and other areas are thin. So in that case, we can also put the implant in temporal infratemporal quadrant. Now, this is another example, which is a rare case. This is 1.5-year-old child who had blue sclera and decompensated cornea. The other eye was thicycle. He had hyperextensible joints and skin. B scan was normal. So this was a case of Ehlers-Danlos syndrome. You can see the vision was hand movement positive in other eye. The other eye is lost because of its thicycle eye. And this eye had 3 PKs already done. The pressure was 32 on tonopen. Fundus result was not seen, but the retina was attached on B scan. So in this case, there is no question of doing other procedure, and there is slight visual possibility in this patient. So we cannot do and also a cyclodestructive procedure was very difficult because the sclera is very thin all around. So to preserve whatever vision the patient had and provide visual rehabilitation, the best was to try putting an implant in this case, which was again difficult because the sclera was so thin all around. Yeah, so sclera was thin all around, along with the conjunctiva was scarred, and 3 PKs were already done. So it was a difficult case. It was very difficult because the sclera is thin, so it was difficult to take even a bite in the sclera. So this was how traction suture was done. Luckily, we had very healthy conjunctiva, was very good, and tenons were very thick in this case. So that's why we were able to put implant there. And since it was a victotomized, the plan was to put the tube in the sulcus, in the pars plana instead of the sulcus. So it was once the sclera was the implant was anchored to the sclera, it was put, the tube was introduced into the pars plana. So around 5 millimeter, it was the entry was done around 5 millimeter from the limbus, though the limbus was very diffuse in this case, difficult to identify. And then first the residual vitrectomy was done, and then the tube was inserted into the pars plana after priming. So if you are inserting the pars plana, you have to put the tube a little longer because there are chances of blockage of the tube with the vitreous. So this is how the tube was introduced in the pars plana. And then the rest of step was same as before. The graft was covered with the scleral patch. But here again, we cannot suture the graft, so we used we used the acrylic glue to fix the conjunctiva over the graft. This was the post-op result. You can see the tube was in situ. So IOP was well controlled, but there was exposure of the graft in post-op period. So again, the graft repositioning was done. We can finally we can see the successful bleb over here. And after that, after some time, the 4th PK was done, and the child was able to see something. At least he was able to walk independently. Now, if we compare the result of tube versus trab, this is a landmark study which included 212 patients and in 17 centers. 107 patients were included in tube and 105 patients were included in trab group. So what was found that both tube and trab resulted in a good IOP control up to 5 years. However, the tube surgery was associated with more use of glaucoma medications in initial first 2 years of surgery. The cumulative success rate of failure was 29% in the tube group, but very high of around 46% in the trab group. And also the need for reoperation or reprocedure was much higher in the trab group as compared to the tube group. So visual loss occurred as similar in both the groups. So conclude, I can say the tube surgery is a very good technique to control intraocular pressure in patients in which the conventional surgery is mostly going to fail, and also the cases where it has already been failed. And also certain cases, some extreme cases where there is no question of doing an implant, doing a conventional surgery or trap. So the glaucoma drainage implant provides an excellent tool in our armamentarium to control the intraocular pressure in such complicated situations.